Components of inflammatory response. Inflammatory mediators. Vasoactive mediators increase vascular permeability, resulting in increased blood viscosity and stasis. They recruit and stimulate inflammatory cells through leukocytes margination and drilling, with subsequent adhesions to endothelial cells, diaperesis, and migration to extracellular compartment. Vasoactive mediators include anaphylatoxins, bradykinin, histamine and serotonin, integrins and selectrins, leukotrienes, prostaglandins, platelet activating factor, complement system C5a, cytokines, interleukins and interferons, colony stimulating factors, soluble bacterial products, particularly formulated peptides, lipooxygenase pathway products, leukotrienes B4. Phagocytosis and degranulation are end results of leukocytes in extracellular compartment. The vasoactive mediators result in specific ocular inflammatory response, including vascular dilatation, increased vascular permeability, and chemotaxis. The vascular dilatation appears as ciliary flush, increased vascular permeability appears as aqueous flare, and chemotaxis represents aqueous and vitreous cellular inflammatory response. The inflammatory cells include antigen, antigen peptide, immunoglobulin, neutrophil, eosinophil, B lymphocytes, plasma cell, T helper lymphocytes, natural killer lymphocytes, mast cell, basophil, macrophage, dendritic cell, endothelial cells, and fibroblasts. Inflammatory cells. Polymorph nuclear leukocytes, or neutrophils, are bone marrow-derived cells. They represent the first line of cellular defense and are the primary cells in acute inflammation. Polymorph nuclear leukocytes constitute 40 to 75% of circulating white blood cells. They have multilobe nuclei with 3 to 5 lobes and pink granular cytoplasm. The function of polymorph nuclear leukocytes include margination in venules, transmigration across endothelial barrier and extracellular matrix, attacking microorganisms, and phagocytosing bacteria and foreign material. Polymorph nuclear leukocytes marginate in venules by adhering to vascular endothelium through cellular adhesions molecules or the CAMs, selectins, integrins, intracellular adhesions molecules ICAM1 and ICAM2. They also transmigrate across endothelial barrier and extracellular matrix by chemotactic factors as complement 5A, substance P, leukotrienes, interleukin 8, and fibrin split products. Polymorph nuclear leukocytes attack microorganisms through cytoplasmic polypeptides, reactive oxygen and nitrogen radicals, production of digestive lysosomal enzymes, and cytokines that destroy pathogens and may induce ocular tissues damage. They also phagocytose bacteria and foreign material, resulting in abscess formation. Talking about abscess formation, abscess is a focal collection of polymorph nuclear leukocytes, whereas suppurative inflammation represents polymorph nuclear leukocytes with tissue destruction, pus formation, as in conjunctivitis, dacrocystitis, keratitis, scleritis, and endophthalmitis. Polymorph nuclear leukocytes predominate in acute inflammation and Behçet's chronic disease, whereas in viral infection, lymphocytes predominate. Other inflammatory cells are the eosinophils, which are bone marrow-derived cells involved in allergic reactions and parasitic infestations. They have bilobe nuclei and pink granular cytoplasm. T-cell production of interleukin-5 activates eosinophils. Esenophils help in parasites-associated inflammatory reactions, including cell-mediated cytotoxicity, toxocara endophthalmitis, control of inflammatory process, histaminase production. Eosinophils also modulate mast cell-mediated reactions as vernal and allergic conjunctivitis, asthma, and atopy. They also phagocytose antigen-antibody complexes. Mast cells, or tissue basophil. They are fixed tissue cells present in substantia propria of conjunctiva, iris, ciliary body, and choroid. They share in both acute and chronic inflammation. They resemble plasma cell, but stains positive with Giemsa stain. Mast cells bind immunoglobulin E to surface, whose contact with antigen causes degranulation and release of histamine, heparin, and prostaglandins E2, as in allergy or immediate hypersensitivity. They also cause acute anaphylaxis and allergic conjunctivitis. Mast cells secrete cytokines, thus sharing in induction of cell-mediated immunity and wound healing. Lymphocytes. Lymphocytes are cells of chronic inflammation. Their origin are stem cell precursors within the bone marrow. Their subsequent maturation occurs in peripheral lymphoid tissue. They have round blue nuclei with scanty cytoplasm, and they are 10 to 20 micrometers in diameter. Lymphocytes are the key cells in humoral and cell-mediated immune responses. Lymphocytes are classified into multiple subtypes according to a surface marker protein: T cells, B cells, null cells, which are non-T or non-B effector lymphocytes. T cells. T cells are bone marrow-derived cells that mature in the thymus glands, and they are found in the paracortical zones of the lymph nodes. They are active in cell-mediated immunity, and they help in lymphokines production. There are various types of T cells: effector T cells, cytotoxic T cells, regulator T cells. Effector T cells, delayed hypersensitivity T cells, which interact with macrophages, express CD4 marker on their cell membrane, and release cytokines, interferon gamma, and tumor necrosis factor beta. Cytotoxic T cells. They are cytotoxic to tumor cells and virus-infected cells. They express CD8 marker and secrete gamma interferon that kills viruses, virus-infected cells as well. Regulator T cells, which are helper T cells, suppressor T cells. Lymphocytes also include B cells, which are bone marrow-derived cells found in cortical follicles of lymph nodes and mature into plasma cells. They are active in humoral immunity through immunoglobulins production. They also help in neutralization of toxins and immunity against bacteria. Null cells, which are non-T, non-B effector lymphocytes, include natural killer cells, lymphokine-activated cells, and killer cells. Inflammatory cells also include plasma cells, which are activated B lymphocytes. They are elliptical in shape with eccentric nucleus and nuclear chromatin clumps around peripheral margin of the nucleus, giving the cartwheel appearance. They show basophilia due to ribonucleic acid, which occurs in rough endoplasmic reticulum, which is the site of immunoglobulins production. There is perinuclear huff, halo, due to decreased staining intensity near the nucleus, which is the site of Golgi apparatus. Plasma cells are the antibody factory, responsible for antibody synthesis and secretion. Antibodies are directed against antigens or altered tissue components. Evolution of plasma cells. Plasmacytoid cells, Russell body, and Morilla cells. Plasmacytoid cells. Rough endoplasmic reticulum disintegrates and is replaced by granular eosinophilic cytoplasm, representing immunoglobulins. Russell body. Round immunoglobulin crystal formed in the constipated plasma cells, and the nucleus is extruded. Morilla cells contain multiple grape-like Russell bodies. Presence of numerous plasmacytoid bodies, Russell cells, and Morilla cells in a tissue reaction signifies a chronic, long-standing process. Macrophage, histiocyte or monocyte. Macrophages are tissue cells derived from blood monocytes. They are the main cells in chronic inflammation. They represent the body's primary phagocytic cell and are normally present in tissues as microglial cells in brain and retina. They are large mononuclear cells with eccentric reniform nucleus and are 12 to 40 micrometers in diameter. Macrophages are the second line of cellular defense, inflammatory effector cells. They have enormous phagocytic capacity to clear dead cells, cell debris, and pathogens with little tissue damage. They regulate lymphocyte responses, antigen presentation, monokine and growth factors production. They also transform into epithelioid cells and inflammatory multinucleated giant cells. In the eye, macrophages frequently contain phagocytized substances as lens material, melanin, lipid, blood breakdown products. Epithelioid histiocytes or activated macrophages. They are groups of cells superficially resembling epithelial cells. They are primary indicators of granulomatous inflammation. They have abundant eosinophilic cytoplasm, large vesicular nucleus with nucleolus, and these cells are arranged in syncytium with faint cytoplasmic membranes. Aggregates of epithelioid cells in different parts of the eye are given specific terms in granulomatous inflammations. Keratic precipitates, clusters of epithelioid cells on corneal endothelium in anterior uveitis. Coeb Busacca nodules on iris surface in uveitis. Snowball lesions, epithelioid cells in vitreous in pars planitis. Candle wax lesion, where epithelioid cells aggregate around retinal vessels in sarcoidosis. Dallenfuch nodules composed of epithelioid cells and or hyperplastic RPE deposited under RPE in sympathetic endophthalmitis. Langerhans cells, which are bone marrow-derived cells belonging to monocyte macrophage group. They have dendritic pattern with cytoplasmic extensions and clear cytoplasm containing Barbeck granules. They constitute 3 to 8% of cells in human epithelia, including skin and conjunctiva. Cell markers include monoclonal antibodies directed against cell surface antigens, including T4 and T6 markers, class II histocompatibility antigen, and intracytoplasmic marker S100 protein. Inflammatory giant cells. Inflammatory giant cells are formed by fusion of epithelioid cells or amitotic division of the nucleus of a single cell. Langhans giant cells. They have peripheral rim of nuclei, homogeneous cytoplasm, and are found in tuberculous granulomata. Foreign body giant cells contain or surround foreign material and thus useful for identification. They have random nuclei within the cell. They also show wall-off, which are large foreign bodies that they cannot digest, like precipitates on intraocular lens. Two-tone giant cells. They show a ring of nuclei surrounded by a peripheral rim of foamy lipid. They are characteristic findings in xanthomatous diseases such as juvenile xanthogranuloma and other lipid disorders such as necrobiotic xanthogranuloma and Erdheim-Chester disease.